Hello, good afternoon, everyone, and welcome to our today's webinar. We are delighted to have with us and look forward to an insightful session together. It's my pleasure to introduce our speaker, Professor Nidhi Chongchitnant, MD Thailand. He is an internationally respected dermatologist with more than 40 years of experience in practice, teaching, and mentoring. Professor studied medicine at Chulalongkorn University, trained further in US at the Medical College of Georgia and New York University, and later became the Director of Education at the AmeriPath New York Ackerman Academy of Dermatopathology, working alongside with the legendary Dr. Barnett Ackerman, and today he continues to share his expertise as a professor of pathology in Thailand and as a board member of the Asian Archives of Pathology. We are truly lucky to have him with us, and I know you will enjoy his real-world insights. Just a quick note before we begin, feel free to drop your questions anytime at the Q&A box, and our facilitator, Dr. Su, will bring them during the discussion. For everyone's convenience, microphone will remain muted, and today's session is being recorded. And may rename yourself if you wish. And okay, welcome our professor for the presentation. Thank you.
Hello. Hello, everyone. Yeah. Okay, we'll start the session now. These are cases from headquarters of this year. Just miscellaneous cases, but they are interesting. Okay. I hope you all see the whole slide scan. What you saw in the scan is the same thing that we see before for signing the cases. It's the same slide. Okay. They are divided into three groups: the melanocytic lesion, the skin tumor in general, and inflammatory skin diseases. Okay. For the first case, I hope you have seen all these slides. Case one is a man, 76 years old, an ulcerative mass at back. The lesion size is about 1.5 centimeter. At low power, is a tumor, blue, and has some area of the lighter color, but the dark area is, uh, is mainly dark blue cells. The tumor is not homogeneous. There are some variation in the tissue. This can be the primary skin tumor or soft tissue tumor. Okay, when we're dealing with tumor like this, we scan at the various magnification to get the characteristic. And this is mainly spindle cell tumor. It has high mitosis, and we cannot get much from this power. The differential diagnosis for malignant spindle cell tumor or for skin and soft tissue will be a lot. There are there are five or more groups of tumor cells. They can be fibrohistiocytic tumor, smooth muscle cell tumor, peripheral nerve sheath tumor, skeletal muscle tumor, adipose tissue tumor, vascular tumor, and other mean it's unclassified. Each one, the prototype of each has characteristic that we can look for. But the majority, in practical point, those that are not well differentiated has a lot of overlaps feature. We look at them and we don't know what they are. We have to use immunohistochem for characterize some biochemical properties, and it will be a big issue in the soft tissue tumor. But in this case, what we can get from the H&E stain is that some tumor cells carry melanin pigment. It's only a small, tiny, small area or on one edge of the tumor. And if you look at the epidermis, the junction of the tumor and epidermis, there are few tumor cells in the epidermis. The tumor cells in the epidermis, they are round cells. It's quite unusual for spindle cell tumor to have round cell component in the same area. In the same area, we may have some so-called epithelioid lymphoma or sarcoma that have epithelioid shape, but that's the majority of tumors. But to have mixture of this is quite unusual, and it signifies that this could be a melanocyte lesion. Melanocytes have so many morphology, from lymphocyte-like to giant cell to balloon cell to small, to so many things. It has to come in differentiation in almost every cases. So with this, it make our job easier. We suspect this is a melanoma, and we have to confirm. We use immunohistochemistry, the S100, Melan A, SOX10, and SMB45. They all positive. So this is diagnostic for melanoma. The Ki67, 30% is high. So this is a malignant melanoma spindle cell type. The problem will be that if this marker, they are negative, now we have big problem. We have to go back to the list and try to find some features of each and make the immunohistochem to no, not and have to do immunohistochem to support what we think, and that's a big issue in the soft tissue tumor. We are not include that in this discussion. Okay, that's the first one. The relatively large size tumor of skin is some melanoma spindle cell type. Case 2 is a woman, 68 years, a small lesion, only 5 millimeters on right arm. At low power, this is a small, relatively symmetry. It has sharp edge of tumor on one side. Another edge is not that sharp, but it has pigmentation here. We look at this area, we see the nest of melanocyte here. So this is a melanocytic tumor, but is it a nevus or a melanoma? The small size tend to favor nevus, small size and symmetry. If it is a nevus, it's gonna be specific nevus or read nevus. But the not so not so favor nevus is that the patient is too old for specific nevus. Specific nevus is mainly in young adult or children. Okay, we look at it higher, and in the epidermis, there is one small area on the slide that you have the same slide as this one. There's only one section that carry this feature, vegetoid melanocyte in epidermis. This is strongly suggests that this is a melanoma. And when we scan into the main bulk of tumor, there will be some area that have so many mitosis. In this field alone, there are 5 mitosis. This is too many for benign lesion. Yeah. So in conclusion, with the changes of the cells in epidermis and high mitosis, this is malignant melanoma, spit-like. It's not red nevus because red nevus has pigmentation. Yeah. Oh, if this happened in a 5 years old girl or boy, we are very reluctant to make diagnosis of melanoma. We can say that it could be atypical split nevus and wet. I have seen uh, quite a few of the split nevus in children as young as a newborn, diagnosed as congenital melanoma or melanoma without question, and after follow up, there is no recurrent or anything. The child happy appear to grow up normally and become an adult. So when we look back again, sometimes split nevus in children are indistinguishable from melanoma. Actually, the original report from Sophia Spitz in 1948 or something like that, her report has a title as melanoma of childhood. She never had a doubt that those cases were nevus. Yeah. She only questioned that why those tumor the patient lived so long, and later this was renamed as a spitz nevus. Okay, the next case.
Click here. Hi. Yes.
The next case is a flat lesion. It's much smaller than the previous two. It's only a flat pigmented lesion. This one is punch biopsy. The diameter is 4 millimeter. Uh, it was biopsy because it had funny looking. The dermatologist look at it. The knee has some abnormal color, has something that a bit unusual biopsy. And this at this low power, we can see that there are nests and single melanocyte at dermoepidermal junction, and there are some inflammatory cells in the upper dermis too. So we look at it, the nests and solitary units of melanocyte. So the differential diagnosis will be is a nevus, a melanoma, or the in-between, the so-called dysplastic nevus. This is a melanoma because nests of melanocyte at the junction, they have abnormal shape. You see this one, and there are smaller one, several of them. The melanocytes, they are atypical, mean that their nuclei are large or have abnormal shape. They stain darkly, and variation of the nuclei is so much. And there are too many nests and solitary units at the dermal junction. Too many for just a nevus. And one important thing is that their pagetoid spread. The, the melanocyte spread into the upper layer of epidermis. This is the features of melanoma, definite feature of melanoma. In another area, their nest and solitary unit of melanocyte extend along the hair follicle This feature is also belong to melanoma. So this is a melanoma that spreads superficially, the superficial spreading melanoma. If the number of melanocytes is less and the shape of the nest are more regular, but found in the area with this severe sun damage, it's still melanoma. It's still melanoma. It's a part of the so-called the lesion, so-called the lentigo maligna or malignant melanoma in situ. That's the three cases of melanoma: larger one, the small size, and flat lesion. Case number 4, a man, 83 years old, lesion from left leg, size about 1.4 by 1.2. The histology, you have 3 cuts on the slide, but this is one of them. It's characterized by the cyst. I can say that it is cyst. The content is mainly quantified cells or keratin. One part of the cyst is lined with the thin squamous epithelium. It has some papillomatosis here, and there's a small part of the lesion. It has still have hypoplastic epithelium, large number of squamous cells. It's this area. So, what is the relationship between this, the hypoplastic epithelium, and the codified cells? If we go back in time, it will be something like this. The what look like codified cells, there will be the large pink acanthotic squamous cell. People can recognize this easily as a keratoacanthoma, or some may call, if the some are aggressive, may call this well differentiated squamous cell carcinoma. But so for this case, the lesion, when it become older, the pink cells mature and become conified cells. The pink cells, the acanthotic squamous cell, they do not divide. The cells that are able to divide, they are only at the basal layer. So as time goes by, the number of cells that mature increase, and to become a cyst containing mostly squamous cell. So this one is an old lesion of keratoacanthoma. This one is an old lesion. Oh, early keratoacanthoma fully developed, and the late lesion, they look different. Some dermatologists who are in the field for quite some time, they can say that when they diagnose keratoacanthoma on some patient, sometimes they ask the patient to wait. They can wait few more months, and the mass become. And later, once they mature, they can drop off, leaving only thin scar. But some just excise them all. Okay, next, in the group of skin tumor, a man, 78 years old, a tumor from hip. The tumor connect to epidermis. There is erosion on the surface. On low power, it has 2 colors. One is pink, the other one is blue. There are some tiny cystic spaces scattered in the lesion. This larger one, there are some smaller one. The blue cells are uniform, it's called basaloid-like, the basaloid tumor cell. The basaloid come from basal layers. The pink cells, they are continuously they are mature cells from the blue cell. You can see transition from blue to pink here. And in the middle of the lesion, there's some lumen. Some lumen. This is the same thing as this side, or only that the pink cell or squamous cell, they are larger, and the cystic space, they are larger. If we, in this case, if we reduce the number of the blue cell to just one layer and the pink cell to just one layer, leaving the lumen intact, you will get the lesion like this. A duct, eccrine ducts or apocrine ducts. You can see that there will be some cell, once the blue cell outside, the cell that has some pink cytoplasm on the inner side, and lumen. Some of the cells on the outside has clear cytoplasm too. If this structure become tumor, there can be variation that it can be solid or cystic. If the luminal spaces become dominate, they will cyst, but mostly the mix solid and cystic. And because of the various type of cells, if most of the lesions are small dark cell, the tumor will be called poroma or eccrine poroma. We now reduce to just poroma. If most of them are clear cell, they will be called clear cell hydranoma. If most of the cell are squamous cell of the inner layer, they will be called hydranoma. If cell of both outer layers and the cell of the tumor has both outer layers and inner layer like this one, it will be called poroid hydranoma. So this is just one structure and different cell composition give rise to several of the tumor names. But if you know what they look like, we'll understand that. Even in some category like the poroma, there will be some lesion that the tumor cells are in the epidermis only, and it has another name. It's called hydroacanthoma simplex. If the tumor is at the epidermis and the dermis, and they already have the name poroma. If the tumor cells are in the dermis and not involve epidermis, it's called dermal duct tumor. So that before we understand that the tumor comes from this structure, I am to show you the variation in the later seminar. Now, another lesion of the tumor, as man 66 years, lesion of the scalp, the size about 8 millimeter. This tumor has the solid and small, tiny, cystic-like, the ductal component. And the stroma that has characteristic is that pink area that we call is the collagenous stroma, have a lot of collagen. And the blue area that has many cells and the bluish ground substance, we call myxoid stroma. In some tumor, there will be area that have characteristic of the chondroid stroma or the stroma of cartilage. It has mixed features of the stroma, and the ductal component. In some of them, you can see that there are secretion from the surface that look like apophyte cell. Some don't. Some don't. Oh, maybe because this come from the ductal part. The one that has secretion on the top come from the glandular part. And this duct, the cell becomes squamous cell, maybe the process of metaplasia. So because of the mixed features of the ductal and the stroma, it's called mixed tumor. The tumor cells are apophyte. We call it apophyte mixed tumor. Oh, some may wonder, how about eccrine mixed tumor? We have that category too. Uh, the eccrine mixed tumor, they look a bit different. Most of the stroma will be chondroid, and the duct will come from eccrine ducts. I will show that case later in the next class. Okay, the next group is rather easy. We look at it. They are sebaceous cells. A man 70 years old, a lesion on the cheek, 1.2 centimeter in diameter. They are composed of the sebaceous cell. They are pale, mean that they are all mature. The cytoplasm are filled with lipid. They are arranged in lobular pattern. This is one big lobule, this smaller lobule, some elongated lobule. So the differential diagnosis of the sebaceous lesion will be something like this. Is it sebaceous hyperplasia, nevus sebaceous, tumor called sebaceoma, or sebaceous epithelioma? It has two names. Or sebaceous adenoma and sebaceous carcinoma. These are the differential diagnosis for sebaceous neoplasm. The sebaceous hyperplasia normally small, 3 to 7 millimeter, rarely approach 1 centimeter. They are comprised of large sebaceous lobule, a few of them. This lesion has too many of the lobules, and the lobule have abnormal shape. So it's not hyperplasia. Can it be nevus sebaceous? Nevus sebaceous has epidermal and adnexal component. The nevus sebaceous in an infant, in young adult, and older adult, they look different. The nevus sebaceous in infant, they have mainly epidermal component. They look like wart, with some of the sebaceous lobule at the base. When the children are about 15 years old or 20, the sebaceous lobule become bigger and it has more classic feature of epidermal hyperplasia plus large sebaceous lobule. When patients get older, 60, 70 years old, there will be additional annexoneoplasm grow on this one. Some annexoneoplasm will look bizarre. They are called trichoblastoma, or even basal cell carcinoma can develop in that lesion. That's a part of nevus sebaceous. This case doesn't have that feature, so it's not nevus sebaceous. For sebaceoma or sebaceous epithelioma, the cellular component will be about half of the immature and mature cell. The immature might mean that the cell on the outer part of the lobules that have a basaloid appearance and dividing cell, they can divide. The mature, the pale cells, they are non-dividing cell. If the number of the immature cell is less, like this case, about 15%, we'll call this sebaceous adenoma. For lesion to call sebaceous carcinoma, there must be features of cancer cells like high mitosis, atypia of the nuclei, something like that. And sebaceous carcinoma has so many variations. You'll see later. There's one thing that is important in the sebaceous neoplasm is that in some of the patient that has multiple sebaceous neoplasm, that patient may be part of the so-called Moore-Torrey syndrome. This syndrome comprises of multiple sebaceous neoplasm plus malignancy, mostly internal malignancy. The most common malignancy associated with multiple sebaceous neoplasm, they are colonic mucosa or some gastrointestinal, followed by urothelial and other. Just in case that if you see multiple sebaceous neoplasm in a patient, or if you have one biopsy before and you say, oh, this is the third time that this patient had sebaceous neoplasm removed, you should mention to the clinician that could this patient be Moore-Torrey syndrome and can he be investigated for possibility of internal malignancy. Okay. The next one is a woman, 68 years old, small papule on the nose, about 5 millimeter. At first glance, we look at it, oh, dark blue globular mass at the bottom part. That's basal cell carcinoma at first glance. But there's another component between the large mass. There's smaller lobular mass lesion, lighter color, and with some of the sebaceous cells. This part and its smaller component is part of tumor of the same thing. They are not part of normal structure. And this is sebaceous carcinoma. We do immunohistochemistry, the adipophilins that stand for cell carry the lipid droplet. The differentiated one are stand positive. The younger cell that do not yet produce the lipids, they are not stain positive, but a few in the size they do. So this is sebaceous carcinoma. Sebaceous carcinoma has many forms. This is what we call basaloid sebaceous carcinoma. That's about the general the neoplastic lesion of the skin consists of melanocytic, the annexon neoplasm, and of some of epidermal lesion. Okay. Now we go next to the non-neoplastic lesion. The non-neoplastic lesion has pattern of inflammatory response. Each one has variation in the pattern. It's quite difficult for pathologists who do not have training in clinical dermatology because the name of the disease of the skin is already difficult for general doctor. They have some funny names that we when we hear it, we don't have no idea that what it's called about. Like lichen striatus or pagetoid reticulosis, or there's so many things. So it's difficult for pathologists who want to be good in field of dermatopathology. You must know clinical dermatology too, and in the training of to become dermatopathologist, you must spend time in clinical dermatology to get to know everything like a dermatologist. You only don't know how to treat patient. Oh, the pattern of inflammatory response, I will show you just one. This is this case 9, a woman 17 years old from back. The pattern is psoriasiform pattern. The prototype of this pattern is psoriasis. This is what you look here. The elongation of laterales is the main feature. In typical in psoriasis, well-developed lesion, there will be scale on the surface. The scale, they are paracotic layer. There will be some neutrophil in the scale, and the granular layers will be diminished. The so-called, this is dermatopathology. The suprapapillary plate will be thin. There will be some so-called spongotic chain. It depends on the activity of the lesion, and the inflammatory lesion will be confined to the upper part. This is the psoriasis. This one is typical. Now, the clinician normally do not biopsy the typical lesion and send to us. They biopsy the atypical lesion to us, and we will have problem with diagnose them. The life of lesion of psoriasis also vary. Will the early and the late lesion and the active, highly active and inactive lesion, they all look different. Some have even called pustular psoriasis, have collection of micro abscesses in the epidermis, and that's called a pustular variant. But anyway, this one is the classical pattern of fully developed psoriasis. The other one, the next one, a man 26 years old, is also has psoriasis pattern, had the inflammatory cells on the surface. This has erosion, but a lot of neutrophils, white cell, red cell on the surface, and numerous cells in the epidermis. Most of them in the epidermis, they are neutrophil, but those in the papillary dermis, they are different. For skin lesion. And if plasma cell is found in associated with psoriasiform pattern, that's syphilis. When we make a diagnosis of syphilis, we have to have confirmation because it's a serious disease. Luckily, we have the immunohistochemistry strain for treponema. This one is positive. All the brown strings and dots, they are treponema. In the old days, we have to use the so-called Wartin study stone, which is very difficult, and not many labs can do that. But nowadays, much easier. But this is the secondary syphilis. Then the clinician has to confirm with VDRL too. Some case of the inflammatory skin shouldn't be misdiagnosed at all by general pathologists because it's like this case, a woman 51 years old, lesion from face, have a lot of inflammatory cell infiltrate in the dermis, has no pattern, is, or you can call it nodular diffuse pattern. There will be some area in which the cells are closely packed, has a darker color, and some with a lighter color, the cells normally are vacuolated cells. The vacuolated cells are normally they are histiocyte with vacuolated cytoplasm. When we look at it at high power, the vacuolated cell are filled with yeast fungi, the yeast form fungi. So many of them, thousands, millions of them, I would say. And this is typical for Penicillium malefii, or they have the name Thalomyces malefii. This patient has AIDS. If there is no information that this patient has AIDS, you have to call back to the physician that this patient has AIDS. You have to test this one. Could it be something else? Well, before the AIDS era, most pathologists will call this histoplasmosis because they look alike. But the microbiologist will call it back. That it's not histoplasmosis. We culture it, and it turned out to be Penicillium malefii. So right now, we know that if there are too many of them, they are Penicillium malefii. If only a few with granulomatous reaction, then they are likely histoplasmosis. But anyway, all the fungi diagnosis must be confirmed by culture. Okay. There is one category that can mimic this. It is leishmaniasis. Usually, the infection found in the Middle East, but with nowadays people can travel all over the world. We have seen this leishmaniasis a few cases every year. People went to Middle East to have a job and then come back and carry something back home. Just be aware of those. Leishmaniasis will stay negative for GMS and PAS. If you have something like this and PAS negative, GMS negative, and the lab says no, this culture is no problem. You have to think of this is leishmaniasis. This is another one that has a specific clue for diagnosis if you know what clue it is. A man, 32 years old, lesion on right leg. The lesion, the state obvious. What is obvious? Obvious is this one. The center of lesion, tissue of this area is damaged. There are a lot of cells that crush, collagen that degenerate or change, and his shape look like something sharp dig into the skin. This is the insect bite reaction. This is the fang mark of something bite him. Patient may not notice he may be bitten while he was asleep or anything, or something he forgot. The inflammatory response is quite intense. The characteristic is that it have ton of eosinophil, huge number of eosinophil. The reaction like this mainly came from toxin or parasite like a nattostomiasis, lava migraine. They produce intense reaction. I believe that the nattostomiasis is still present, even though it used to be in Thailand. We used to have it 50 years ago, but they are found in the native freshwater fish. It has people who eat raw freshwater fish are subject to this condition. You can eat raw fish, but has to be the sea fish, and also those like salmon or tuna Even though with those salmon or tuna, they have to be frozen at minus 18 centigrade to kill the possible egg or larvae of the parasite. I think it's some tapeworm parasites that found in the salmon or tuna. But in freshwater fishes, they harbor the parasites of the Natostomiasis. And you shouldn't eat fresh, raw, freshwater fish. It's high risk unless that it come from a farm. Okay, this is the insect bite reaction. The number of the eosinophils is just amazing. Millions of them. The case 13, this is an easy one, diagnosable with low power. At scanning level, at scanning power 4 or 2.5, you see that this structure of the dermis is different. The dermis at the lower part is densely packed. The upper part, the collagen is not as packed as the lower part, but still thick. The bundle are thick compared to the normal. This, when we see this, this is scleroderma or part of the systemic sclerosis, or if it's localized to one area, it's morphea. This do not require high power, but just look at it. This is the upper part. This is the upper part. Epidermis look normal. The collagen in the subepidermal area is relatively normal, but a little bit deeper, the bundle are relatively thick now. And at the lower part is densely packed. There will be a lot of inflammatory cells in here. It depends on the stage of disease. In the older lesion, inflammation may be reduced. This is scleroderma or morphea. It depends on clinical lesion. The next one, a man 19 years old from back. This is the diagnostic point is obvious if you know what it is. The epidermis look like almost this part is normal, but the conified layer it flipped. It's flipped. It should be here, but it's not here. Some may think that it can be handled roughly and just rub off. No, it is not. It's the conified layer is separated because the connection with the lower part is weakened by immunological reaction. There is an antibody to intercellular substance at this area. This is in the spectrum of the pemphigus or immunological disease against the intercellular substance. In the classical form, the pemphigus vulgaris, they will be against the intercellular substance at the lower part, but in some cases from the upper part. And this is called superficial pemphigus or pemphigus foliaceus. There are two forms of superficial pemphigus. One is pemphigus foliaceus, the other one is pemphigus erythematosus. Just to be aware, but it look almost nothing. In some time we don't have the conified layers at all. We have just this part, and when we look at it, we have to ask, where is the conified layer? It's not present because it's lift off, and there is a space or so-called vesicular lesion here. This is the pemphigus foliaceus. If we do immunohistochem oilofluorescence, we can detect that there is some reaction here at the upper part. The separation at the subcorneal level, superficial pemphigus. The last one, this is tough. This is the one that require knowledge of the clinical dermatology. Yeah. If you know clinical dermatology, it'll be easier. If you don't know, you still get it, but it's getting more difficult. Patient 6 9 years old on left leg. The patient had itchy skin, and the clinician look at it, then biopsy this lesion. Oh, the clinician look at it and don't see anything, don't get that idea what happened here. So biopsy to send us. We look at it, it's difficult. The epidermis is normal, maybe a little dark. There are some pigmentation at the basal layers, no spongiosity, no reaction, no inflammation here. There are some polyvascular inflammation here, but it's rather non-specific. There are not many cells up here too. Why the patient is? Look at this carefully. Let's see that the capillary here have thick wall and irregular. There's a knob here, partly. There's some that look like part of the collagen, but they don't look like. They look like, but they are not actually collagen. They are so irregular. Pale pink globule. And the spaces in the subepidermis is too dense. Usually, the spaces in the subepidermal area, they are the intercellular, and the stroma here is loose than much looser than. There's something pink in here. This pink and this pink. This is macular amyloidosis. It's amyloidosis, but the thin form is macular amyloidosis. If it's more severe, it will be easier to diagnose. It's called papular or nodular amyloidosis. That will be normal. But the macular amyloidosis is tough one. This is the one of few cases that we have problem. I remember 20 years ago, the clinicians sent us a case and he told us that this is macular amyloidosis. We look at the slide, we say, not, we don't see anything. Or my colleague, Dr. Winju, take that sample to see under electron microscope and found amyloid fibril in that. So this is tough. Just in some cases, it's really tough. But at least if we know dermatology, we can help the clinician and confirm, okay, that's you're right. This is macular amyloidosis. But this one, maybe it's me who helped the clinician. Okay, that's the end. The samples of the what we have in the past 6 or 7 months. If there will be a lot more, if you are interested in this field, we are glad to share. Okay, that's the end of the session. Back.
Okay. Thank you so much, Professor, for your insightful presentations and the practical points of view. We have received several interesting questions from the audiences. And now we'll move to the Q&A sections. And thank you to everyone who has submitted questions. And please be free to continue adding your questions in the box. So our first question is, Professor, for continuing with the case 3, the participant is thinking if that could also be lenticular malignant melanoma.
Yes, it is. We can call it lenticular malignant melanoma is a clinical term.
Okay.
In the clinical term, we just say that if it's melanoma in situ, it's okay now.
Okay. Thank you, Professor.
If we can detect the some melanocytes in the epidermis, we just call it superficial spreading melanoma. As long as it's called melanoma, it's okay.
Okay. Thank you, Professor.
Yes.
And concerning with the case 5, and the pathologist is concerning that she approached this case like the inverted follicular keratosis, and she thinks that these are squamous eddies.
The
Could you
the
please?
inverted follicular keratosis
Yes. Yes.
is a controversial condition.
Yes.
Something is follicular, but some say definitely it's eccrine ducts or apocrine ducts. Some even think that it is both. Has been argued among the prominent dermatologists 20 years ago. And even even now, the morphology of that still controversial. In this case, as I shown you, that the component of the lesion has choroidal cells and the squamous cell uh, that belong to the eccrine apocrine ductal part. The squamous eddy actually is a non-specific pattern. It's, it was related to inverted follicular keratosis from the beginning. But people look at this squamous eddy and came with several conclusions. One is that it is a spiral eccrine duct. When I show you that there is an eccrine duct with the squamous cells around it, when they proliferate and the so-called spiral and was cut in the plane, it will have the same appearance. It may be seen in some conditions, several conditions. Actually, it's related to eccrine ducts more than follicular. So it's a misinterpretation of the original description of inverted follicular keratosis. Yeah, that's my interpretation.
Thank you, Professor. And let's move to the next question. It's about the case 6. And the participant asks, what is the difference between apocrine mixed tumor and chondrite syringoma?
The
Yes.
chondroid syringoma is considered to be eccrine mixed tumor. Apocrine mixed tumor is what we see. The eccrine mixed tumor is not shown. The eccrine mixed tumor has another name. It's chondroid syringoma.
Thank you, thank you, Professor. And so the next question is about the case 8. The participant thought it was a basal cell carcinoma with sebaceous differentiation. Could you please touch it more detail concerning with this area, Professor?
Oh, the first one, if it's basal cell carcinoma with sebaceous differentiation, the first one, this must be basal cell carcinoma. And sebaceous differentiation normally will be single cell, a little dot of the dotlet in the tumor cells. There will be some vacuolated cell, differentiated cell in in the group of the basaloid cell. But in this case, you see lobules of immature sebaceous cell on the surface, several of them. And the streak of the tumor cell connected to from those lobule to the main black tumor. That make me think that it is better called sebaceous carcinoma. Okay.
Okay, Professor, thank you. And now the next question is about the case 11. Could you please explain the difference between the histoplasmosis and penicillium in the H&E features with for the quick
Oh,
view? Yes.
Better
the
not
trick.
do it. Better
Okay.
not do it. They look alike. I remember when I was president, we make a diagnosis of histoplasmosis. The mycologist says no, and
Okay.
he showed us the penicillium in the culture. They look alike. They are yeast form. The difference that I can make is that in case of AIDS with penicillosis, there will be millions of them.
Okay.
But in histoplasmosis, normally chronic granulomatous diseases, and there will be some, not many, and there are some areas that look like TB rather than look like TB rather than something like this. It's a TB that we look like, but we have the GMS stain that turned out to be turned out to be the yeast form fungi that histoplasmosis, and we get it from lung or other organ, not skin. Okay.
Thank you, Professor. And the next question is about the case 15, and the audience want to know, is there any
Oh,
additional stain? Yes.
we use a AE1, AE3 to stain the keratin. We used to think about Congo red or something like that, but nowadays we use the AE1, AE3 because the character of the amyloid is a keratin.
Okay, thank you, Professor.
Uh,
And another question is about the immunofluorescence stains for the participant asked that which are the basic minimal immunofluorescent panels needed for the vesicular bullous disorder?
oh, I think it depends on each of the disease too. Normally we have IgG, IgM, but in our lab when we order immunofluorescent, it came 3 or 4 of them at the same time. We get IgG, IgM, fibrin complement that mainly for kidney. We use it for kidney, but once we order for the skin, the lab send us the same thing. So we can look at IgG, IgM. Yeah.
Okay, thank you, Professor. And the next question is, what will be the best recommended visitor for the immunofluorescence in your practice? What would you recommend as the best visitor for the immunofluorescence stains? Could you
We,
please suggest?
we get fresh
According,
tissue.
yes.
We get fresh tissue. And
Uh,
Tamatha lab, I think there is a type of fixative that used in what we send to Sri Lanka. There's,
No, we send the fresh tissue also.
yeah. In our
uh,
lab, we use fresh tissue.
mhm. Okay, Professor. The next question is on the mastocytosis. The participant want to know to diagnose the cutaneous mastocytosis. Are there any cutoff point for the mast cells to see in the high power field?
See, if you
Uh,
diagnose mastocytosis, it had to go with clinical too. I used to have a skin section that I say mastocytosis because there are about 20 mast cells in just one field. And clinicians said, no, the clinical didn't fit. It's just maybe just it. You have to have clinical correlation in this category. Uh, if it's especially the TMEP, the telangiectasis macularis elliptica perstans lesion, that that's difficult. But if it's mastocytoma or something more, there won't be any problem. But the earliest one to make diagnosis, you need clinical correlation. You need clinical. The number of mast cells do not count because I've seen cases that even with 20 mast cells in just one single field, clinician say no, the didn't fit with the clinical.
Okay. And Professor, and the participant want to know that is there any stain for the mast cell in the diagnosis, or which
We
one
use
would you prefer
yes,
for the eye?
CD 117 is okay.
Okay. What about the special stain like the toluidine and giemsa stain or like
Um,
that?
they are old fashioned. You
Yes,
can use them. You can
yes,
use them when they're old fashioned.
yes. Because in our country, most people are not very affordable. So in the resource limited areas, we have to think about the special stains. So the participant asked that question, I think.
The gyms are staying will be fine because the methylene blue in the gyms are staying to stain metachromatically in that. But the good one will be CD 117.
Yes, Professor. Thank you so much. Um, the next question is about the lymphoma cases. The participant asked that for country with limited resources, which are the minimal IC panel to diagnose cutaneous lymphoma based on your practice?
See, this is the hematopathologist problem.
Okay.
even this even this country, even in Thailand, when we talk about lymphoma, they're gonna stand for something like 20 of them,
Mm,
and it's getting more and more complicated every year. Uh,
mm,
you have to talk to hematologists how the minimum requirement of him, how much he want to go with that diagnosis, with the subtype of that. Some people just want to know one or two, but some want to see everything. You have to satisfy the hematologist, and I think it's a hematologist who will okay, we have enough for this. We don't need more, something like that. You, even here in Bangkok, when I get lymphoma, I send the case to hematologist. I won't do it because our hematologist, when talk to the clinician he has another hematologist that he wants. So it's more complicated than that.
oh, thank you very much, Professor. And the next question is from one of our dermatologists, not pathologists. She asked that in case of erythroderma, underlying skin structures are usually lost. So may I know which site and when we should take skin biopsy from that patient? How do you think, Professor?
Oh, I cannot answer that. Have to ask the dermatologists who have more experience on this. The dermatologist who has high experience on this field can tell you. I cannot answer that though.
Okay, Professor. Thank you anyway. And let's look for the more future questions. That the question is, what advice would you give young pathologists in remote resource limited settings to build confidence in dermatopathology?
You can get resources from internet without problem. The There will be plenty of resources with the whole slide scan image in the internet. In some case, you have to register and pay small fee to access the the material. In some case, they are free, but the problem will be that you must have enough patience to study those things. They are not easy to study, and if you study alone without friends or colleague or teacher to guide you, things getting more difficult, like you play piano by yourself.
Uh, thank you, Professor. So, looking ahead to the future, how do you see digital pathology and whole slide images changing daily dermatopathology practice in the next 5 or 10 years?
The field of pathology, especially dermatopathology, will be replaced by AI soon. We have to adapt to this change. We have to do something better that the AI cannot do. We have to be able to check the AI whether their diagnosis appropriate or not compared to the clinical information. In general, the AI will take over 80 or 90% of the cases, and will do less, but will be more important.
Okay, Professor. So the next question is, how do you approach the skin biopsy with sparse materials where the lesion is only partially presented?
Take deeper cut into the block, get the entire tissues, examine the entire specimen in the block. You get a lot of things from what left in the block. Do serial section of the whole thing, so you may get back the 20, 30 slides.
Okay. And professors, there is another question. After viewing of thousands of cases, what is one entity you will still find more challenging?
See, case 15 is
Oh,
this is
sorry.
oh,
Yes,
oh, I'm sorry.
yes. For the
I'm
case
sorry.
15, sorry, pardon me, Professor. I confused with the questions. The case 15 is I cannot find the pathologist who see the case. She also think that that is a macular amyloidosis, but she cannot find the culprit and any other pathology she cannot find. She's just wondering what made you think that is an amyloidosis cases.
The clinical information that the patient itch, that one thing. The second thing is that the capillary wall that are thick and irregular. They are not seen in normal histology of skin. And as I told that then some amyloid globule, they look very similar to cross-cut collagen, but they are not alike. They are not alike. The spaces in the subepithelial area, there should be some more space, but they are diffusely infiltrated with the pink material. That when I look at the slide, that look strange. Uh, and all the things that I make conclusion that this is macular amyloidosis.
Thank you so much, Professor, for your answer. And we received another questions. The pathologist asked that in small skin biopsy samples, how many levels of deeper cuts are needed to view the H&E stain slides appropriately?
See,
He just
I
wants to
not
know. Yes.
I normally view only one cut.
Oh,
If
okay.
I get the answer, I'm satisfied. If I don't get the answer I want, I ask more deeper cut or serial cut, depend on the situation. And I ask three, sometimes I ask three more deeper cut. In some case, I ask serial the whole thing, like the small sample. I serial the whole thing. It depends on the context of that. If I get the answer from one cut, I just go ahead and sign. It has everything along with the clinical, and I am satisfied. I don't ask three cut in routine. It's burden the lab and increase cost a lot. Say if you ask, I need three cut of everything, and sometimes, and in some case, you get five slides from the beginning. Time three, come back to the 15 slide already. I don't think that is too much for the lab.
Yes, Professor. Thank you. This is the last questions for us today's sessions. So, after viewing thousands of cases in this much years, Ajahn, which is one entity you still find more challenging?
The melanocytic lesion is still difficult in some cases. Oh, yeah, in some cases it's hard to say that this is melanoma or something else. Especially the new category, something that we don't often see, the animal type melanoma or deep penetrating nevus. This is clearly definitive nevus or melanoma. It's something that have to differentiate between benign and malignant, and that thing look so-called look strange or look funny, not typical for anything, and yeah, that's difficult.
Thank you so much, Professor, for your time. And thank
You're
you so much, Professor, for addressing these thoughtful questions. And thank you to all our participants for your thoughtful submissions. For any unanswered questions or anything you would like to know further, please feel free to send me email to us and we will share them with the professor and we'll follow up to you by email. Once again, thank you all for your engagement. And now I will hand back to the Ms. Dr. May for the closing remarks. Thank you so much, Professor.
Thank you so much, Professor Nidhi, for sharing your knowledge with us in such a clear and inspiring way. And thank you, everyone here, for your participation. And your participation really make us webinar very meaningful. Before you go, we would like to hear your feedback, and it will only take a minute to fill out our short form, and it really help us make future session even better. And don't forget, our lab also offers services like INC service, which we offer locally and in Thailand also, and for rare cases and molecular tests and second opinion consultations. And last, we do the digital pathology